Join me, Charlotte Stallworth, Vice President of Business Development and Innovation at Stanford Medicine Children's Health, as we engage the brilliant minds driving change in healthcare, unraveling the mystery behind the next medical innovation. Hi, everyone. Thanks for joining our discussion today of reducing health disparities via data-driven innovation. I am so pleased to welcome my friend, Dr. Gary Puckrein, an expert in this space. Dr. Puckrein is President and Chief Executive Officer of the National Minority Quality Forum, a nonprofit health equity research organization, which he founded in 1998. The National Minority Quality Forum aims to enhance national and local initiatives by utilizing evidence-based approaches to reduce preventable illness and tackle health disparities among racial and ethnic minorities and special populations. Dr. Puckrein also is the Executive Director of the Alliance of Minority Medical Associations, which comprises several medical associations representing underserved populations and was established based on evidence of significant disparities in healthcare treatment and outcomes among these groups. Hi, Gary. Thanks so much for being here today.
Oh, Charlotte, great to be with you.
Wonderful. Please tell us about your journey and how you move forward to create the National Minority Quality Forum.
So obviously my doctorate's in history, so I have no medical background per se. So I will say that I studied classical medicine, Hippocrates, Aristotle, and Galen. So I do know a little bit about bloodletting and leeches and that sort of thing. But clinical medicine, I know nothing. Actually, how I got started in this, it sounds like a really weird story. But when I was growing up, you can see I'm an old dog. There were 4 television stations. And one of the television stations was Walter Cronkite. He used to tell the evening news. And at the end of his evening news, he would give the stock market report. You know, my family didn't have any stock, but my dad seemed to be enthralled with the idea of where the stock market was going. And I would always say to myself, you know, I'm really interested in how many people died today. What did they die of? That seems to be more important than the movement of the stock market. And so I've always had that thought in the back of my head. I ended up, I was tenured faculty at Rutgers and got a little bored with that and went to the Smithsonian and published a magazine at Smithsonian for a number of years. And when I stopped doing that, I decided I wanted to start working with minority medical, organizations that had publications, but really weren't getting value from them, which brought me into the world of medicine because I started working with the National Dental Association and the National Medical Association. And as I was working on their journals, one of the things I began to appreciate, this is the 1990s now, that the large companies were really interested in blockbuster medications, and they were not really trying to understand what was happening down at the community level. And when I was publishing the magazine at Smithsonian, a lot of our work focused on zip codes. And so with zip codes, even in the 1990s, you could predict what magazines people wore, read, what television stations they watched, what consumer stuff did they buy. And I thought, well, you ought to be able to do the same thing with medicine. That if you understand the geography, and today that's what we say, right? Your zip code is predictive, but back in the 1990s, I assumed that was so. And so as I started to work with those publications, I realized that no one was collecting the data at the zip code level. This is back in the days before, you know, everybody was running around trying to collect health data. And so I set out on a mission to collect health data. Back then, you could write the Robert Wood Johnson Foundation with an idea, and I wrote them and said, I'd like to collect, at that time, it was a mortality data, and they gave me a grant to go off and collect it, and there I was, right? And later got some support from the Bureau of Primary Healthcare. Marilyn Gaston was heading that organization up back then. And away I went. And so we've been collecting health data now for over 20 years. We have a database of over 5 billion patient records. We collect data on about 160 million lives a year, covering well over 100,000 different conditions.
That is amazing. I'd love to hear that journey moving from the Smithsonian to, applying the thought of being very specific with data to, maybe sell magazines or, sell other products, but looking at, and also looking at the stock market, but looking at ourselves, our people, and what their experiences are based on their zip codes. I think you're definitely ahead of your time, and you're right. There are a lot of people looking at that right now and appreciate, the work you're doing and have done. Can you tell us about any specific challenges or experiences that made you focus on the health equity research? I mean, you did say you were thinking about how many people died, but can you just talk a little bit more about that?
Well, certainly, if you live the African American experience, you know about inequities.
Yeah.
The Margaret Heckler report in 1984 documented the inequities, but Booker T. Washington did that in 1915, and W.E.B. Du Bois did it in the 1890s. And so there was no surprise, at least among African Americans, that they were getting crappy care and their lives were being shortened by it. And so one of the things that I learned from the zip codes is that there are roughly 38,000 zip codes in the country where people live. 70% of African Americans live in 2,500 zip codes. About 70% of Hispanics live in 2,500 zip codes, though that's changing because of migration and other things. So you can understand disparities by just the zip code where populations live. And in those communities of African American and Hispanic zip codes, and to a lesser extent Asians, and certainly Native Americans, we don't provision healthcare to them. I know there was a time in American history where inequities were okay. They were by law and by custom. They were okay, and we haven't yet grown out of that. We still put public policies together that disparate populations. So in any case, the answer to your question is that from the work I've done at Smithsonian, I anticipated that in those zip codes where the minority populations live, the inequity that Margaret Heckler was reporting on would occur.
So were there any challenges in developing this and getting started as you're collecting this zip code information? Were you just able to go out and start collecting it?
Oh, God, no. There were all kinds of challenges and continue to be challenges. So healthcare data is really controlled by feudal lords in this country, right? Everybody, they're feudal lords. Everybody sets up their castle and build a moat around it and a drawbridge and whatever else they can do, protect it so that it's not accessible to everyone. And so it's a challenge to collect that data and make it available. So certainly that. The financial challenge is enormous. Had no particular grant that said yes, go forth and collect data. So there was the financial challenge. There was the technology challenge. The technology changes all the time, and what was good in one moment is no longer practical. And then there's a staffing challenge to pull together a team of epidemiologists and statisticians and data specialists and to collect, manage, and analyze the data. So it was and continues to be a challenge.
So, you talked about being inspired because, as an African American and the experience, you understand their health disparities, and you decided to collect this data. And of course, data itself is very important because you had a goal there, right? Not just to have the data and prove to yourself that this happened, that this was existing. So can you talk about maybe how you've used the data, maybe for maybe it's the evidence base, right? We're in, scientific and academic research. People are doing research, collect data to prove a certain point, then to move on to make a difference on the point they've proved. So can you talk a little bit about how you're using the data, the importance of it?
So the way to think about NMQF, we're really applied science.
Okay.
Even though we're happy to write articles that push the boundary of knowledge, and we do that. But really what we want to do is to take the findings and bring them down to the community level. So besides collecting all that data, we have a faith-based alliance. We probably a network now with over 50 churches around the country. We have a barbershop alliance and beauty shop alliance. And we take that data, in the analytics of it, we repurpose it so that we can go to churches and give them information that we have curated that they can have confidence in into how to manage their diabetes, their atrial fibrillation, their lupus, their multiple sclerosis, et cetera. And so we really do take that data and apply it. But I think more broadly, we've just come to the place where the American healthcare system has to be reimagined if you're really going to do equity. It is not possible to do equity in the current system because it wasn't built to do that. It was built to have a tiered healthcare system where everybody seemed satisfied with the fact that you didn't provision healthcare to some people. You just said, we can't afford to give them healthcare, and so we don't. And the point I want to make, which is, we've been talking a little bit about in our office and don't really have a solution for it quite yet. Everybody thinks when you're talking about health equity, you're talking about minority populations. But white populations suffer from health equity as well. And they really don't have strong advocates, if you think about it for a second. You're kind of hard pressed to think of an organization that is advocating for rural whites and the kind of the absence of public policy that supports them. So we end up closing down their hospitals. Right?
Yeah.
Like, what do you think you're going to do when you close down a hospital in the community? Is that going to advance their healthcare? I don't think so. But that's the point, right? That this is a broad American problem where we have to rethink, how we're provisioning healthcare, and that's kind of the work that we're doing, using the data to drive that conversation.
So yes, so you're saying you're curating the data and providing it back to the communities and the people to empower them, kind of give them the information, education they need to help improve their health and manage their health, but still understanding that there lack of resources in the communities as well. So this is only one part of the solution to empower and educate the communities, give their data back to them for their own, hopefully better health, but there's still so much more work to do.
Sure.
I think please go ahead.
I was just going to say, we have a program called the Cancer Stage Shifting Initiative, which is a precise example of how we use the data. So what we know is that there are communities around the country, because of public policy, we've exposed to carcinogens. There's no argument about it. Ben Chavis did the report in ¡84. Bill Clinton acknowledged it in EPA and put the social justice program together. So there's no argument that indeed is happening. So when you expose them to carcinogens, you will necessarily elevate their risk for cancer. And so there are communities around the country, in Houston, Texas, and Flint, Michigan, Milwaukee, Cancer Alley in Louisiana, where the people believe that they're living in a cancer cluster. But when you go into those communities, what you find is, by public policy, we also don't give them health care. And so they get diagnosed late for cancer. They don't get screened early for cancer. the cancer has metastasized, their life expectancy is short. They don't get put into clinical trials, and the relationship between the medical community and those communities are poor. So what we decided to do, number one, is to identify those communities, but also there's some new science that's coming out called multi-cancer early detection screenings. They screen, some of them screen for 50 cancers at one time with one blood draw, and they can diagnose patients at stage 1 and 2. So we are putting programs in communities around the country to use those diagnostics as surveillance tools, so that what we're doing is we are going in, screening them by cancer type, because they can, screen for 50 cancers, but also to look at what stage they are. And the power of that is cancer care is getting so much better that if we can diagnose you at stage 1 and 2 cancer, we can improve your survival rates dramatically. And so with this surveillance, we identify them at stage 1 and 2, and then we consent them into an interventional arm where we give them access to best modern therapy. And then the final arm that we're working with the Milken Institute is that we also co-create the financial model, the reimbursement model, to say, so here's how we pay for it. And that's the example of changing the healthcare system by, on one side, bringing quality care in, but also looking at the economic models to make sure that these things can get paid for.
I love that approach, and that you're, identifying, and maybe based on data that's already available, those cancer clusters, and, surveilling them, as you're saying, diagnosing them, and allowing them to enter into a clinical trial, right? That you say the interventional arm, and move forward from there. And I think, some of the work, you and I met years ago, that you've been working on is really to try to help underserved populations have access to clinical trials, help pharmaceutical and device companies understand the importance of having diverse population in their trials when they're creating a drug or a therapeutic or an intervention to impact the broadest population possible, right? When you think about the economics, it's in their best interest to do that. But in the past, and probably still in the present, many trials are focused on a certain population and not looking at all people. So can you talk a little bit about your work there?
So you're absolutely correct that we need to diversify our clinical trials for a lot of reasons. From a scientific perspective, it's easier to learn with a heterogeneous population as opposed to a homogeneous population. And so just for the speed of advancing the science is important. But what's also happening is there's a demographic shift in the country, right? California, Texas, New Mexico, Georgia, Florida, Maryland, New York, New Jersey. I'm just, America's changed. Yeah. And so if you are going to bring new products and services into the marketplace, you have to build them so that they're able to work with diverse populations. I mean, that's the answer. It's a business conversation about whether you want to be able in the marketplace to have your products and services, be able to reach the broad market in America. And so we think that that's compelling, that companies now have a business reason. It's not a nice to have, it's a business reason. But also in doing that, because you just can't do the clinical trials, now you got to solve the access issue, right? And so that's where the policy part of it comes. And so when we look at it, we see the future of medicine is really about working with diverse populations and providing them with the care that they need.
Thank you, Gary. Could you also talk a little bit about the collaborations that are required to achieve some of the visions you have for American healthcare and reducing those disparities? I know have multiple partnerships. You could talk all day and not explain them all, but could you give us maybe one or two examples of how you're partnering?
I think that the best way to summarize it, living is a collaborative experience, right?
Yeah.
So one of the examples I have, and I always find this marvelous, right, is that trees collaborate. They lock their roots up. They're not, you know, in the forest, you may see a tree standing alone, but when you look down below, it's networked with other trees, right? And human beings are the same way. I know people like to think that, you know, Ayn Rand, don't do anything for anybody unless it helps you and all of that sort of thing. But that's not reality, right? In order to really um, expand longevity, to improve the quality of life, it's a collaboration, and medicine is a collaboration. And there are lots of people with a lot of different skill sets that come together to keep us healthy. And so what we try to do, because that collaboration breaks down in these underserved communities, because they're not reimbursed and reinforced and strengthened the way in which they should be. And so, and a lot of it is that these innovative companies have not had the capacity, the staff, or even sometimes the inclination to go into these communities. And so what we try to do is open that door and have those relationships with the barbershops and the beauty salons and key opinion leaders and bring them together with the innovative companies around a purpose. And the purpose is really to improve the quality of life, to get rid of the inequities, to open up that marketplace so that these innovative companies you know, have something, some place to sell their wares. And so that's the way we think about it.
That's amazing. And so, you know, those collaborations that you're having on the industry side of things, government side, and of course, impacting communities. So when you're, you know, working on behalf of those underserved communities and you're going back and working with them and maybe bringing in those other partners into the community, how do you help the community leaders and the people to participate in the study and in the work that's envisioned? Are they maybe involved beforehand, before maybe you've already met with them and then bring in the collaboration? How does that look and how do they react?
Yeah, so first of all, we never go into a community without doing a listening session and understanding where the community is, what's their expectation, and you know, start from there. You have to build that community trust, because these are communities that have been taken advantage of in lots of ways, and so you have to take a moment to build that trust. But also in building that trust, we're also talking about building infrastructure, meaning we work collaboratively with them, we resource them, we hire them, we train them, we bring them into the mainstream of the healthcare system. The example would be, let's talk clinical trials for half a second, right?
Okay.
So the US spends over $245 billion a year on clinical trials. None of that money gets into those communities, none of it, right? And so what's happening is that the old guard wants to come into those communities, collect their data, and leave, and not hire them, not work with them. I mean, it's the worst kind of exploitation. I mean,
Yeah.
what are you doing, right? And the point is, and they get a lot of money to do that. And sometimes they come to us and we say, they're not doing that. It just, we can't do that, right? Now, if you want to come into the community and you want to lift that community up, you want to train them, you want to build infrastructure in there, you want to make them part of the clinical trials enterprise system, we're all in for that, because that way there's a strong partnership, and the folks get to understand the value of a clinical trial, both in terms of clinical, but also in terms of their life's work. And so, you know, I think that's the way you have to think about these things, that these communities need infrastructure. They need to be able to participate in the ecosystem as well.
Yes, definitely. And I think it's like kind of a value proposition, right? For all of the people involved, the people in the community understanding that when people come in maybe to have them participate in a trial or in a study, there's going to be some benefit to them down the road, tangible, that can be explained up front, and also for the pharma or other government entity or company that you're working for, and for yourself as well. I mean, your group as well, right? So I think we all may have different motivations. It may be that someone's motivated by the economic results versus the social impact versus their own personal, family and life story. But if the goal is the same, right? Maybe the motivations don't have to be aligned. If we can all achieve the goal and it improves or decreases those disparities and increases parity and the health in those underserved communities. So you have all of this data. You said you had, I want to say 160 million lives or something like that. I mean, it's a huge amount of data. Do you find now that with so many people focused on data, even healthcare systems thinking about data, startups and others thinking about data, that there may be some future uses of that data that you've not leveraged it for before, or maybe providing access to it by certain groups that had not previously partnered with you?
Yeah, so a lot of the data collection that's going on, particularly with large industry partners, are really about shareholder value, right?
Yeah.
They're not really focused so much on what I would describe as mitigating patient risk to lower people's risk for adverse events, going to the hospital, or lowering their risk for going to the emergency room, et cetera, et cetera. And so when we collect the data, that's where we're focused at. We're focused on using the data to really improve health outcomes and to partner with patient advocacy groups, because collecting and maintaining the data is expensive. It's usually expensive. And so we want to build collaborations with patient advocacy groups and others who are like-minded, who really want to serve the community with the data. I think that's the future of healthcare. I know that right now there's $4.5 trillion on the table, and everybody gets very excited about that, and so lots of people want to invest in it, but that's not healthcare, and the outcomes are going to show, because, and this goes back to the cancer moonshot, right?
Yeah.
If you develop all this science and technology and you can't figure out how to bring it into these underserved communities, it might as well not exist. All you're going to do is create the haves and the have-nots when you don't have to. And so the way in which we look at it is that the best partnerships is not to say to those who are interested in shareholder value, no, there's a way in which you get to shareholder value while you simultaneously provide quality care to the community. They're not mutually exclusive. And in fact, the way I would say it, we want to pay you to keep us alive. We're excited about that. We want you to do that, right? That's a good thing. And sometimes some of my friends think that, well, you can't make money keeping people alive, and I disagree. I think that's a great thing. It's very, it's almost like B.F. Skinner, right? It's behavioralism. We keep rewarding you to keep me alive, and you keep doing it. Well, that's a hell of a man. I love that, man. B.F. Skinner would love that model. Why not?
Yeah, it's totally obvious when you say it that way. Of course, there's an economic value in keeping people alive and participating in a system, right? Versus not. So yeah, I totally get that.
Oh yeah, it's a Skinnerian box. We love it.
So I'm just thinking about that. We talked about people like kind of ignoring underserved communities, and even now I think there's a lot of social consciousness about, we need to have health equity and bring everybody along. And I hope that's a self-sustaining movement. I know we're all doing our part to help keep that going. Are there any like laws or regulations or other elements within maybe not culture, but in our system that could help promote and, really just kind of in your example of incentives or rewards for doing a certain behavior, is there a way to make that more obvious or to enhance it? Maybe a role of the government or other entity to help that along?
I would say the answer is absolutely yes. I think HHS needs to be reimagined. It's in the 20th century someplace, lost, as a matter of fact, and it doesn't see the future. It doesn't understand what the future is. The future of the 21st century is all about health and sustainability. It is absolutely about sustainability. Don't let anybody get confused, right? So it was a great essay done by Jackson Turner Maine in the 1890s. It was talking about the closing of the American frontier. And his argument was that the frontier was closed now, and it was kind of anticipating the whole industrial movement in society, right? And that was seen as that essay that he wrote was a signal event, right? There's an article to be written about the transition from that industrial age into the age of human sustainability. That's our future. That's the challenge. The Earth is maturing. Its capacities and the way in which we use resources are challenging it. I mean, we can see it with climate change, but we can talk about other things that are happening. Elon Musk is talking about populating Mars, and Jeff Bezos wants to go to the moon and extract resources from there. We certainly have to be interstellar. Anybody looking at the data knows that. But those are big time challenges. Those are things that think about it. If you're going to the moon, you're going to the Mars, how are you going to deal with diabetes? I mean, and so if you understand what the future looks like, you understand that the healthcare system that we have right now is inadequate for that purpose. The way I look at it, it's the natural forces are driving us to other places, and we need to give ourselves the space and ability to make the kind of changes and adapt to the realities that are in front of us.
Yeah, you're right. Suddenly, when you were talking about that and giving those examples, I was thinking of Star Trek and thinking about like, what is healthcare like in our imagined future of, ourselves? And, in Star Trek, you have like the scanner thing, and you have little
But
things
that's
taken
what that early
aside
detection
that'll
stuff
fix
is.
you. And it's like
Yeah,
healthcare is like pretty easy. Yeah, let's just
yeah,
go to sick
yeah,
bay,
yeah,
and there are all kinds of tech for
yeah,
anyone who needs it, right?
yeah. But that's what AI, that's what these new multi-cancer devices and screening tools and other things, that's what they're all about, right?
Yes.
That's the future, right? And what we're not doing is we're not accelerating it. So another example would be, so when the flat screen TV came out, it was like $25,000, and two people could own it. Now they're like $3, right? But that's what medicine should be doing. It should be figuring out how do we do these things in a cost efficient way, because the end product is sustainability. The end product, that's the goal. And unfortunately, that's not the way in which healthcare is conceived right now. But I'm optimistic about the future.
I am optimistic as well. I agree with you. I think there are some elements of the way our healthcare system is arranged with a lot of people's insurance tied to their employers, and some employers not providing insurance. And there's kind of you're right, the construct of some of our current state need to be disrupted and innovated. And
Yeah.
a kind of a shift in our mindset as well. Like health is not like an elite position to be in. It's to be
Yeah.
healthy, right? It's
Yeah.
like the the baseline position is
Yeah,
for
yeah,
have a healthy society, or at least
right,
provide healthcare to have a healthier society.
yes,
That tide lifts all boats, right? So
yes.
it seems fundamentally obvious that things have to change, but it's just
So,
the mechanisms required in so many areas to make that happen.
yeah, I agree with you. It's a big old battleship. It's going to be hard to turn around. Got a lot of vested interest in the status quo that don't want it to change. Uh, but it has to. There is no option. And so it's the fact that there is no option that gives me confidence that it will occur. It may be very sloppy and messy and difficult sausage making, but yeah, it's going to happen.
Yeah, it's inevitable, right? You're right. I mean, we have to continue to evolve and move forward. And I personally, as well, am optimistic about what this is going to look like and how it happens.
Yeah.
So maybe like looking ahead, when you think about the kind of that imagined future, what would you say are some of the goals of the National Minority Equality Forum, or you personally, with using data, being informed by the data to advance health equity and reduce disparities?
Yeah. So I tell my staff, we're chasing the tortoise. The tortoise gets to live 250 years, and we're supposed to be smarter than the tortoise, right?
Right.
And so that's goal number one. Let's go chase the tortoise. Let's go figure that out. Um, nature has given us great abilities in the area of regenerative medicine. We can do, our minds enable us to do unimaginable things right now. And when I go back to classical medicine with Aristotle and Galen and the blood leeches and all of that, and see the remarkable ability to get down to the genomic level and open the book of life and begin to um, um, use it to improve healthcare. Um, you know, we have the capacity to do really wonderful things. Um, uh, and so what I say to my staff is, let's go chase the tortoise. Let's go see if we can catch it, and do that in underserved communities. That's the challenge, right? That's a challenge worth getting up for every day.
That is a challenge worth getting up for every day. I'm going to add that to my quotes. Chase the tortoise. Yes, it's like compelling to think of what that is.
Yeah.
So I think we're nearing the end of our time here, but I'd love to have you provide any other thoughts you'd like to leave with our audience. You know, these are physicians, nurses, regular people interested in health innovation and hopefully health equity as well.
We want you to operate at the top of your license. We have to figure out how we enable you to do that. Don't despair. You know, the system right now, you know, tosses barriers in your way. But I think there are voices out there who are committed. I marvel at the work of physicians and nurses and the challenges that they face, the difficulty of the work. It's incredible. I couldn't do it, and we need to make sure that we give them the appropriate space so that they can make good decisions for patients and not feel as if they have to withhold care because of the way the financial mechanisms are working. Um, that's not a good thing, and so we're anxious to help them do that.
I appreciate that, and I'm sure they appreciate hearing that. I know I said that was the final question, but could you talk a little bit? Could you just maybe give a comment or two? I know we talked about the National Minority Equality Forum. I didn't talk about the other entity that you formed. I'd love to allow you to speak on that as well.
There are minority serving clinicians out there. When you run the data, what
Yes.
you see is that there are a specific group of clinicians and hospitals that serve minority populations. And nobody writes about them. Nobody tries to organize them as a voice or help them use the science for those communities. And so, their folks are not in the clinical trials, and so they have to learn on the job, as it were, how to take care of them, how to take those new sciences and make sure that they work effectively in those populations. And so we want to recognize them. We want to bring them to the fore because they're actually the future because of the demographic shift. This is why the objective reality compels, because it is not like before, and so we want to work with them and figure out how to get their folks into clinical studies, how to get their voices heard in terms of what they need to provide care to folks, that they just don't end up writing a paper that nobody reads. But how do we translate that into public policy? How do we connect them to the policymakers so that there's a real and genuine understanding of how to serve these populations? It's a lot of work, but they're doing marvelous things right now with the capacity that they have. We just want to help them.
I love that. That's wonderful. And that group is called the Alliance of Minority Medical Associations. I apologize for not saying it. I was very casual in mentioning that. I appreciate that work and really inspires me for us to connect again offline about maybe some ways that, some of my partners and I could be involved in that. I can see some interesting ways to kind of work together and be aligned. So would love to connect with you again.
We're anxious to have you because at NMQF we're not doctors, right?
Right.
We're advocates, and so having clinicians who understand the work at hand and what needs to be done is an important part of the collaboration that we try to build.
Definitely. I mean, we have a vision and we need to collaborate
Yes.
and innovate to get there. And you're doing an amazing job of bringing all the data together, the various number of players together, and also that concentrating on those healthcare providers serving underserved populations. So the scope of your work is admirable, and I really honored to have you here today and really appreciate you being here.
Well, thank you so much for the invitation. Appreciate it.
Thank you, Gary.
Great.
Have a wonderful day.
Yeah.
Thanks everyone for joining us. See you next time.